here we are. Okay. For the last speaker, you get a policy, advocacy, government affairs guy from Brooklyn, and I'm going to try and bring that Brooklyn charisma so we end on a flourish. Okay. So my name's Dennis Johnson. I'm with Children's Health Fund, and I am here to talk about kids and health equity and some of the issues that I've had to deal with in my 25 years and that I've seen in my 25 years working at Children's Health Fund. So I'll start with, let me see, which button do I push? Oh, there we go. Okay, well, I'll talk a little bit about the fund and what we do, and then I'll talk about what we found when we realized the issues that were facing kids who needed health access and the transportation barriers that got in the way. And then I'll talk a little bit about one of the programs in our network that we're focused on right now in terms of trying to address some of those access barriers. So we were started 30 years ago in New York, and we're a program, a network of programs actually, 21 programs in 14 states in the District of Columbia. And we've seen about, just under 4 million kids in the 30 years of our existence, 4 million encounters, I'm sorry. Close to 300,000 kids. And we have about 50 mobile units on the road. Most provide primary care, some provide dental health care, some provide mental health care. So we're a mission-driven organization. We take a hybrid approach. We use what we learn in our clinical programs to inform our policy work. As the head of policy advocacy and government affairs, my job is to talk about those experiences and to convert them into usable material to leverage policy and legislative change in Washington and elsewhere. We have rural programs that are located in Idaho, West Virginia, Arizona, Tennessee, and Mississippi. Some of our other programs in Florida and Michigan arguably provide some health care in rural communities as well. So that establishes our bona fide zone. When we focus on health equity, as per the purpose of this meeting, when we talk about health equity, and when we ask ourselves, what does that mean from a CHF perspective, what we're talking about is the fact that there are certain things that kids need, and that simply, really, are there enough resources in the pipeline to put as many children as possible onto a path of success? And success for us means kids have access to a medical home, which I'll talk about in a second, that children are healthy and ready to learn, and that is really critical because anything that interferes with that process, as people have mentioned all day, really does interfere with the likelihood that they'll be successful in life. And so we want to make sure, we want to ensure that that health status isn't undermined or interfered with, and that opportunity isn't undermined for the kids that are poor and medically underserved. So the medical home model for us involves care. I'm sure most of you know this already, but it involves care that's continuous, comprehensive, accessible. That's very key. Family-centered, coordinated, compassionate, and culturally effective. And we've talked about, in different ways, all of these today, but that's the kind of care that we think every child deserves. That was a model of care that was pioneered by the American Academy of Pediatrics some time ago. We were, I think, smart enough to pick up on it a long time ago and to put it at the core of our mission. But since then, we've learned a lot. So we've learned that in order to stay current, we need to have an enhanced medical home model of care, one that has a lot of bells and whistles relative to the first model, but that we all look at as key components, as you know, indispensable aspects of care. So mental health, oral health, increasingly electronic health records, telemedicine, still in its nascent stages, but coming on strong, and care and a component that I'm going to spend a lot of time talking about, the balance of my presentation, which is transportation services. So, our rural programs, and before I went into becoming a talking head, I actually was recruited to and spent 2 years doing program development at the fund. So I was the interim director of the network, and I do have some experience in putting programs online. And I can say that putting together an effective rural program was a challenge, with a very rigorous learning curve for me and for the organization. And in order for us to be successful, we learned that we had to let our efforts be informed by an adaptive learning process, one that recognized and sought to understand that there are a range of factors, the aggregate impact of which define the frame for health access in underserved communities. Again, we've spent some time talking about that today. And layered on top of that, you needed to be committed to a collaborative strategy to find solutions in that community. And we only started making real progress when we started listening. So as you can imagine, being a New Yorker, we think we know everything. And going into rural communities and working with very dedicated health providers, this was a learning process for us to just listen and to see what you could learn from people who would always be forthcoming if you had open ears. So what we did learn was that there were some very interesting frame-setting factors. Intrinsically, we understood the mobile nature, or we knew the transportation issue was going to be a big issue because mobility was at the core of what we were doing. We were sending mobile units out to deliver health care. But the other social determinants obviously had a very big role in the frame-setting process for us in determining what would be effective in terms of a program model in communities. So poverty and socioeconomic status, obviously very large. Workforce shortages, which we were acutely aware of because the medical leadership of our programs are they're pediatricians, and everywhere we went, there was difficulty in recruiting folks, and this is what we would hear from populations. Transportation was a big issue. We started to learn that 20-some years ago. As a result of we mounted a national child health caravan, launched in New York and terminating in the Delta region in Clarksdale, Mississippi. We did a host of community events along the way, different states, Kentucky, Tennessee, West Virginia. And everywhere we went, we would ask folks, are you finding out and having difficulty getting health insurance coverage? And they said, yeah, we're getting covered. There's some good programs out there, and we're very focused on that, but we can't get to the care. They say, we have coverage, but we don't have access. So we knew that was a problem. And then we learned in some of our programs citizenship status, and then the ever-present cultural barriers in trying to build an effective program in places where there were unique cultures and you come to it as an external force, not quite understanding what they are. So today, you might have heard my remark earlier when I asked the question. I was pleased to see that Sharita brought up transportation because, how many people in the room here come from a transportation background or are involved in transportation in any way? Please raise your hand. Yeah, that's about typical. So we have one hand raised, and I've become the transportation whisperer. I go to meetings and I talk to people and I want to know why there's if the focus is on health access, that we're not having more involvement by people who are in the transportation sector. So lack of transportation, a critical health access barrier for kids. We've done some research over the years, and I just wanted to point out a few highlights. How am I doing on time, by the way? Oh, good. Okay, I'm doing okay. So what we found in a survey that we did some time ago, as you can see, it's somewhat dated, that 39% of U.S. residents did not have public transportation available in their community. 39%. And 11% of U.S. households did not own a working vehicle. So you can see right there that this would be a problem. That this transportation availability varied significantly by area of residence. So we started to learn some things with this survey. And then we also learned that variation in terms of area where folks lived was profound, and that in rural communities, so 25% of folks in rural communities were reporting that they had, let me see if I have that right. Yeah. Only 25% were reporting transportation availability. So they did not have public transportation. People in the rural communities were showing far less of a likelihood of being able to access transportation to get to health care. And what does this mean in terms of health outcomes? So we found that 4% of U.S. children, regardless of income or insurance status or area of residence, missed a health care appointment because of transportation in the previous year before the survey, and that number went up to 9% of children in poor and low-income families. So we saw 2-3 million children around the country were missing routine health care. And the reason that's important is because if there's an emergency, children are going to get to health care. You know, even if they have to air vac them, they're going to get to emergency services. But it's the routine health care. It's the EPSDT well child visit. For those of you, do you know what EPSDT is? Early periodic screening, diagnosis, and treatment. Okay, so these are the developmental screenings and stuff like Head Start. You know, if you're missing those types of appointments, then you're putting a child at risk of delay and not having appropriate treatment of chronic conditions. We found 63% of those who missed an appointment missed 2 or more visits during the year, and that 31% of patients reported that they later sought emergency care for their condition. All right, so what that told us, that as an access barrier, missed opportunities for immunizations and routine well child care, increased incidence of untreated chronic illness, increased use of emergency rooms, and increased in preventable hospitalizations. The bottom line for us, transportation, from our perspective, is a key component of the medical home model of care, and that improved accessibility and promotion and utilization would contribute to improved health outcomes for children and families. So, to try and quantify that in a way that would allow us to speak about it in a more informed way, and where the transportation disadvantage existed, the Health Fund pioneered development of the Health Transportation Shortage Index, which is a quantitative measure that essentially scores communities and indicates where, much like the health professional shortage area indication would tell you that certain communities lack providers, our index would tell you that a community is at risk of inappropriate health access because of transportation problems. And we can talk more about that because we have it up on our website, or I'll send you a copy. I've got about 5,000 of them. So, all right. So, I want to take a closer look at one of our programs in Idaho. So instead of a success story or a case study, I'm going to just talk about the framework for action that's ongoing with one of our rural programs. The Idaho Children's Health Project is based at Family Health Services, which is a federally qualified health center, actually a group of them in south central Idaho. It's affiliated with St. Luke's Hospital. It provides medical, dental, and behavioral care. And it serves a population of low-income, uninsured, and migrant seasonal farm workers in south central Idaho. And our piece of it is we support a dental health mobile clinic. And I've had a series of conversations, with the medical leadership of that program, and I have over the years. It was started 12 years ago. And I asked him, I said, you know, what do you, in terms of your rurality, which is a word I'd never learned until I started talking to folks. It's hard for me to say it sometimes, but, and he had a lot to say. And he told me that when they have some new developments. Folks who would typically come through as migrant workers and be there for the summer and then head back are now staying. And so that population is growing, and with that growth, their needs are growing, and he's trying to adapt. Now, Family Health services has a span of about 80 miles of clinic miles. The clinics are 30, 40 miles apart in some places. And he told me stories that were, frankly, pretty harrowing about access to care. And in communities, small towns, rural areas where folks literally were an hour away from a healthcare facility. So they were going without care. They had no health providers living there. Some of these communities are up near Sun Valley, very wealthy communities, but there aren't any providers there that take Medicaid. So people will travel long distances. Of course, they don't have access to public transportation, so it creates a problem. We try and bring the medical care out to them in the van, and sometimes they get it, sometimes they don't. So it's further exacerbated by the geographical location, lack of providers, and of course Idaho rejected the ACA Medicaid expansion, so that made things even worse. So now they're trying to figure out how do they move forward. And I'm hoping, I've got some ideas, and we've actually done this work and helped to convene stakeholders, transportation stakeholders, medical stakeholders in Mississippi, in the Delta area. And you can read about it in a previous report that we did for the National Academies on the intersection between health and transportation. This is how the table is set in that community. The lack of transportation is recognized, but it's unresolved. So what we do know is that insurance isn't enough, that coverage doesn't equal access, and that even though the safety net program coverage is improving, because the transportation deficiencies are unresolved, you end up in a cycle that gets triggered. And that cycle starts with suboptimal access to primary care, which then rolls over into suboptimal management of chronic conditions. Then you get overutilization of the ER. You get increased referrals to more costly specialty care. So the healthcare costs go up, even as the healthcare outcomes are poorer. It's just a cycle that's ongoing. So the takeaway for us is that, from our perspective, that in rural America, transportation access is the critical connective tissue supporting health access, opportunity, and ultimately equity. Now, to be considered, we have a number of things that we're looking at, and we can talk more about them during the panel, during the question and answer. But we know that, for instance, Idaho is just brought a new non-emergency medical transportation provider on board, very high tech. We need to monitor and make sure, because those brokerages have not worked all that well in many states in terms of providing the kind of access that we think is appropriate. We need to educate and convene stakeholders around things like our Transportation Shortage Index, where we geomap the state, and then sit in a conference with folks on the transportation and health side, and we say, what do you think about this? What can we do? How can we work together? We need to enlist the support of institutional partners like hospitals, community health centers, other human service providers, because if you improve and upgrade the transportation in a community, everyone benefits. We need to engage state transportation officials who can be very receptive and aren't often called to the table when it comes to planning on how to rationalize and distribute transportation resources and funding. To reach out to community health and education partners, because it does have profound implications for children for their learning by being as healthy as possible and being able to succeed. And finally, there's a local economic development play, as we say in New York, with this as well, because if you can build the medical transportation infrastructure in underserved communities, involving local independent contractors, if you can involve community colleges and helping to license and to bring people online and small businesses that are based in this area, you keep those healthcare dollars circulating through those communities. That's good for communities, and that's a local economic development program at work. And on the federal side, I could go on about this forever, so I won't, but Medicaid needs to be protected, obviously. We need to preserve robust support in the budget for National Health Service Corps and community health centers. And then there's a whole conversation that we need to have about telehealth and how that should work with Medicaid, not just Medicare. So thank you very much.